Antipyretics, if they're running a fever, this would be probably Tylenol that you're giving them. Analgesics would be if they are experiencing pleuritic pain, or just pain from having pneumonia. Because a lot of these patients do work pretty hard at breathing, so they're using their intercostal muscles a lot. You may be giving them pain medication. Rest, but not to the point where they're confined to bed. So hopefully they're up, at least getting from bed to chair, maybe ambulating a little bit. But if they are experiencing deoxygenation issues, where they're becoming more hypoxemic with activity, they may need to be on bed rest for a while. So that will just be dependent on the patient. Antivirals. Remember, there's a small window to give antivirals once symptomology occurs. So typically, they aren't often used. And then, of course, prevention through vaccination is recommended, especially for the older population, because their immune systems tend to deteriorate as you get older. Increased fluid intake. Now, the only population that comes to mind as far as contraindicated would be like your heart failure patients. They already have too much fluid on board. Maybe your renal patients that have renal failure. People who tend to hold on to fluid, that giving more fluid would put them at risk, would be in that contraindicated category. Those that are not contraindicated, oftentimes you use IV fluids, PO fluids, and some textbooks now are even talking about 3 liters a day. I've seen other textbooks mention 2 liters of fluid a day. That's all not only to keep them hydrated, but also to try to loosen up or liquefy those secretions so that they can mobilize them and expectorate them and get rid of them. And then nutritional support's always important. One, because we use our intercostal muscles to breathe. And so if they start to atrophy or somebody becomes malnourished, they're not going to be able to recover as quickly. Okay, what nursing diagnoses come to mind when you're thinking about pneumonia? And you guys can put this in the chat.
Ineffective airway clearance. I'm going to put that.
Ineffective breathing pattern. Okay.
Send it.
Good. You guys hit all 3 of them. Impaired gas exchange, ineffective airway clearance, ineffective breathing pattern. Some that you may not think about: acute pain, fatigue, activity intolerance. So there are others that are applicable, but you guys hit the highlights when you were prioritizing them. So overall, our goal is to, 1, treat the infection and get rid of it, right? But to optimize their breathing, to make it easier, to make sure they maintain their oxygenation, because we know that's vital for what the organs and tissues need. And then how do we do that? Anybody come up with some interventions?
Monitor their O2. Raise the head of
Head
the
of
bed.
bed, 30 degrees, at least. That's our minimum. Okay, oxygen. Instead spirometry, good. So vital signs, pain levels, okay. Okay, think about deep breathing and coughing, right? A lot of times you'll get that with the incentive spirometry use. Medications, things like antibiotics, make it more comfortable to breathe, and that's maybe where your pain medications play a role if they're experiencing pain when they take deep breaths. Humidification, good point, and we're going to talk about that when we get to our oxygen delivery devices. Okay? We may need to suction. I mean, if they can't bring up their own secretions, maybe nasotracheal suction would be warranted, but very uncomfortable. So if we can do things to help the process. The other thing that doesn't get utilized a lot that might help break up secretions is chest physiotherapy, where you're basically cupping your hands and you're beating on the posterior part of the back, and trying to use vibration to break up secretion. Okay? And that one gets forgotten a lot. Not sure why it doesn't get done more often. All right, so keep those interventions in mind. So a lot of what we just talked about in interventions are going to play a role in every subsequent pulmonary problem that we discuss. So TB.
What was the term for that technique you said of percussing the chest?
Chest physiotherapy.
Chest, thank you.
CPT is the initials for it. So tuberculosis, infectious, obviously affects the lungs. It can affect other parts of the body as well. In fact, I've encountered people that have TB of the bone. They're not necessarily treated the same way. In other words, when we have a TB patient that comes in, we immediately put them on respiratory isolation. It should be airborne precautions. Now, airborne precautions should be a private room, HEPA filtration. Think about your COVID patients because they're pretty much on airborne precautions as well. Full PPE, N95 mask. TB's in the same category for airborne transmissibility. We don't see a lot of it in this country. Some of the other countries have given vaccinations, the BCG vaccine, to their patient or to their populations. And so if you have individuals that come to this country from one of the other countries that have received the BCG vaccine, they can't do the PPD that we all get screened every year because they'll pop positive. They'll automatically react to that. So they may have to undergo, some people, or I guess some occupational health departments are doing chest x-rays. Some have negated doing a routine chest x-ray, and they pretty much just have to answer a questionnaire. But anybody exposed with a patient, especially those that we didn't know about that may have been in the hospital for a certain number of hours or days, you might get a notice from your occupational health department say you need to come get tested because we had a patient that ended up testing positive for TB that wasn't initially identified as a TB patient, and therefore you've been exposed. Yes, prone positioning, which we're not going to really get into until we get into acute respiratory distress syndrome, which occurs in MCA 3, and that's really where we'll talk about prone positioning. So you won't really see it done a lot for pneumonia or TB patients. Yes, you can prone if they're intubated. So much fun. Big challenge. Okay, so if we do suspect somebody with TB, getting the acid fast bacillus test, the AFB, and the gram stain done is going to be vital to diagnose. It's poorly diagnosed through a chest x-ray. They'll probably do one, but it's not a good diagnostic tool for TB, as are the other tests, the AFB and the gram stain. Okay. There has been drug resistance, and so we do have TB that are now being identified as being resistant to some of the normal drug therapies that we give to TB patients. So you see there's the MDR and there's the XDR, and these are resistant to certain types of drugs. Typically think about how COVID's transmitted through the air, through the airborne droplets released into the air, coughing, sneezing, speaking, singing, anything that puts those droplets into the air and then exposes somebody to, for several minutes, to being able to inhale those droplets. You hear oftentimes people that have been flying on planes that they need to get tested because somebody on a plane was positive for TB. Although the airlines, especially with COVID, have really tried to tell people that their air is very well circulated, although every time I fly, I get sick. But anyway. Signs and symptoms. Fatigue, malaise, those are very vague symptoms. Anorexia, weight loss, also very vague symptoms. These individuals will have low-grade fevers. But one of the keys is having night sweats. That's a really typical problem or symptom with this problem, and one that should stand out as, oh, let's think about TB. They're typically going to have a cough, but a bloody sputum doesn't show up in the majority of these patients. Only, about 10% of patients will have bloody sputum. And then, of course, pleuritic pain, which we know occurs with other types of respiratory problems. So you all know about the TB test, the skin test. I'm not going to go in detail with that. Chest x-ray they'll do, just because anything respiratory seems to get a chest x-ray. However, it's not a good diagnostic tool for TB by itself. So therefore, analyzing the sputum is going to be key. And then there are some interferon assays that can be used to identify TB as well.
Assays.
And they're listed here. Okay, nursing care. Outside of treating it like any other respiratory problem, you're going to use the same interventions pretty much. The only additional one that I think makes TB unique is putting them on airborne isolation. The drugs will change. You'll get drugs like rifampin, isoniazid, and typically those medications can cause their urine to turn like a orange color and can be staining. So there are some unique issues with some of the medications, but these medications are going to be given for quite some time, several months. So obviously these patients don't stay in the hospital that long. So then it becomes, what is your teaching going to be upon discharge? How are you going to keep the community safe? Do they need to isolate away from family members? And typically to get them off airborne precautions in the hospital setting, they need 3 negative AFB tests done. And then we can remove isolation, send them home. But they're going to be on long-term medications and also probably have follow-ups with their public health department, because it must be reported to the public health department and identify other people that might have been exposed to this patient.
Dr. Bowman.
Sure.
About, what is the patho behind the night sweats with TB? Is it like
not sure?
Oh, okay.
Sorry.
No, it's okay. I just know it usually is like a hormonal imbalance, but I was wondering if they have a low grade fever, why they're also manifesting night sweats.
Yeah, I'm not. I've never delved into the patho with that specific symptomology. There might be some information that you can dig up if you're interested. Okay, chest trauma. So this is blunt force trauma to the chest. Oftentimes,
sorry, can I interrupt? Just
Sure.
Because it was on the textbook, and I just wanted to mention it.
Okay.
So it was related to the airborne isolations.
Yes.
So I was surprised. I don't remember if it was a TB question. I think it was a TB question. So it expected both. I thought that airborne isolation included standard precautions.
Of course, because you're in
So,
your
so it was one of those questions where actually it was select all of the above, and so I just selected the airborne instead of selecting the standard precautions. But I just found it interesting. I was like, oh, what if
question are you referring to?
It's on the textbook.
Oh, in the textbook.
I'm sorry, in the textbook, one of those at the end of the chapter questions.
Let me take a quick look.
Oh gosh, I can't remember which. I mean, I might have even been on the HIV. I think it must have been on the HIV, but because of the HIV has tuberculosis as one of the problems, then it actually included standard precautions and airborne.
Okay, so there is a question here. It says a patient with TB has been admitted to the hospital, is placed on airborne precautions in an isolation room. What should the nurse teach the patient select all that apply, expect routine TB testing or to evaluate the infection. No visitors will be allowed while on airborne precautions. Adherence to precautions includes coughing into a paper tissue, take all medications for full length of time to prevent multi-drug resistance, and wear a standard isolation mask if leaving their airborne infection isolation room. Is that the one?
Yes, that's the one. So it was the standard thing that actually got me by. I was kind of like, what? Airborne? Yeah, that's fine. But then again, the standards.
The standard isolation mask if leaving the airborne infection isolation room, that's the one that got you?
Yeah.
Okay. So that's different than standard precautions. When you mention standard precautions, I'm thinking gloves.
Yeah, and I probably didn't read it properly, and I probably need to go into that question a little more because I'm still confused a little bit.
Typically, we aren't going to want that patient to leave the room at all, right? But we don't restrict visitors either. When visitors go in, now they may have changed their practice a little bit with COVID, but prior to COVID, when anybody walked into an airborne isolation room outside of a healthcare provider, they could wear a surgical mask. Okay, they didn't have to wear an N95. I know a lot of that has changed with COVID specifically because typically when we thought of N95 masks, we had to be fit tested as healthcare providers. So we went through a special testing process to find the mask that fit us, right? This is an OSHA requirement. So OSHA dictates the safety for healthcare providers in a hospital, and that's where that N95 and wearing the right one played a role when you dealt with airborne precautions. However, visitors aren't protected by OSHA. They're not employed by the hospital. And if you think about what the CDC has said, even with COVID, is they're basically saying, no, you can wear a surgical mask. You don't have to wear an N95.
Wow.
Unless you maybe are immunocompromised, maybe you're more susceptible or so forth, right? So when a patient's family member goes into an airborne precaution room, typically they're going to only be asked to wear a surgical mask, not an N95. However, a healthcare provider must because of OSHA standards. So when you have this leaving the isolation room, let's say the patient has to go down to X-ray. Ideally, if it's just a chest X-ray can come to them. They don't have to leave. So if they have to do a test that they can't come to them, like CT scan, MRI, something of that nature, typically what the hospital is going to do is only use a surgical mask for that.
Okay. Thank you. Really, really interesting. I didn't even know that. I was really surprised about that. Yeah, thank you.
Oh, you're welcome. So chest trauma. So again, impact by some kind of force. Usually you're going to find this in motor vehicle accidents, but certainly anything that impacts the chest can cause it. This would be to the point that you have rib fractures, possibly even a sternal fracture, even though that bone is very strong, so that's very difficult to crack. And these rib fractures can puncture lungs. Okay? Certainly they can do injury to the heart as well, but we're going to pretty much focus on the lungs. Other trauma could be gunshot wounds, stabbings, anything that could penetrate the lung tissue. So first and foremost, when you are dealing with anybody, even if you're out, you don't know what happened to them. If they're found down unconscious, remember BLS, you're looking at airway, you're establishing airway. If they have a pulse, you're not doing compressions. If they don't have a pulse, you are. But when you have medics come on the scene, what we're doing is trying to assess and establish an open airway, especially if they do have a pulse already and we don't need to do chest compressions. You can do that one of several ways. You can do a jaw thrust, where you're literally moving the mandible out by pressing on that. You can feel on yourself, there's an arch there where your jaw kind of rounds out, and so you're pushing that mandible. That's safe to do in a spinal cord injury patient that you suspect could have a cervical spinal cord injury. Okay. A head tilt chin lift is that hyperextension of the neck. That would be unsafe to do in a spinal cord injury patient or someone that you suspect has an injury. But that's another way that you can open up an airway. In the hospital, you'll have access to oral pharyngeal airways as well as nasopharyngeal airways. Nasopharyngeal, you can use either nostril. The only instances where you can't use it if they have some underlying nasal fracture, maybe even a facial fracture that might be displaced, or maybe a nasal deformity or some kind of problem with their turbinates or their notes. That may be a contraindication to the NPA. But even a semi-conscious patient can accept an NPA. It's not comfortable. They're rubber, you lubricate it when you put it in, and basically what it does is it goes past the tongue, which is one of the major reasons why somebody obstructs their airway, and it opens and reestablishes that airway patency. And OPA is an oral one where you're literally sticking in the mouth and you're getting behind the tongue. You can only do that in an unconscious patient because that stimulates the gag reflex. And so a semi-conscious patient, you may induce vomiting on them. Okay, so that would be a risk for aspiration pneumonia. I'm not sure if I have any pictures of those coming up, but certainly Google. I'm sure you can see videos. I know it's in your clinical skills textbook about OPs and NPs as well. All right, auscultating breath sounds. Are there diminished? Are any absent? Are there adventitious sounds? Certainly we're back to administering oxygen, especially with hypoxemia. If you have any open wounds, again, we need to cover them because that's called a sucking chest wound. And we need to reestablish that negative pressure within the cardiothoracic region. And if that isn't covered, we can't establish that negative pressure. And that's what we use to drive ourselves to breathe, is negative pressure. If you have anybody that has impalements, you'll see these on some of your ER shows coming in, having fallen on a wrought iron fence and how they just cut the fence away and left it impaled in the patient. Knives. It's important not to remove those impalements. Let surgery do that. It's a controlled environment that they can address bleeding. Because if people a lot of times remove the impalement, now you open yourself up to exsanguination because you can't stop whatever vessel was lacerated, like they can do that in surgery. Positioning to optimize breathing. We talked about ways to do that with raising the head of the bed. Now you might encounter some instances where you have spinal cord involvement, and that's going to be a little bit more challenging to optimize their position. You can't necessarily just sit them up using the head of the bed. You can do reverse Trendelenburg, where you take the whole level of the bed and you reverse it so that you raise the head above the level, and you can optimize it that way. Anybody who has a pneumothorax, in other words, say a rib punctured a lung, you have the sucking chest wound, for example, they need a chest tube to reestablish the expansion of the lung. And these patients may need to be put on ventilators. So think airway, breathing, circulation. If they're bleeding out and they don't have a patent airway, the airway still comes first. Okay? And reestablishing some kind of a breathing pattern. Tracheal deviation. So we know our trachea is midline. If it shifts to one direction or the other, that's tracheal deviation. That means pressure is building up in the intrathoracic cavity, pushing all of that anatomy to one side. That's considered a tension pneumothorax. And that's an emergency that needs to be corrected. And physicians are typically the only ones that can do that by decompression. Hypotension, that's obviously low blood pressure, irregularities in somebody's heart rhythm, chest pain, JVD, which might indicate we've got some pulmonary hypertension or pressure building up, causing issues of the right heart being able to pump into the lungs. muffled heart sounds, which typically coincides with maybe fluid in the pericardial sac. And that's called cardiac tamponade, where the heart is not going to be able to stretch and contract until that fluid gets removed. And again, that's needle aspiration done by a physician. Certainly any type of bruising or contusions on the chest might indicate that there has been chest trauma, open wounds, lacerations. And then something called subcutaneous emphysema. That's air that has escaped the lungs that's now depositing into the subcutaneous tissue. So when you touch the tissue, it's going to feel like a crackle and a pop under your fingers. Sometimes you can feel this in patients who have laparoscopic surgeries because the escape of air from the abdominal cavity kind of deposits into subcutaneous. That's not life-threatening, but excluding that type of surgery, if you have somebody coming in from some trauma and they've got this sensation of popping under their skin, I would start to think about a pneumothorax in that patient, which needs to be addressed with a chest. So briefly, like I said, tamponade, fluid building up in the pericardial sac, which is going to cause problems with the heart being able to pump blood, and the pericardiocentesis done by a physician is basically putting a needle into the pericardial sac and removing that fluid to reestablish cardiac contractility. Flail chest. If you have a patient who has a fracture of 2 or more ribs, sometimes you're going to see this paradoxical chest movement. We know the chest should rise and fall a certain way. So if it looks abnormal to you or asymmetric, that's that paradoxical movement that we're referring to. That often happens when you have multiple rib fractures. Could be a problem in the sense of causing, we know there's, what it will tell us is that we know there's something wrong with the rib cage. We need to look further and make sure the lungs have not been damaged and that a pneumothorax is not also occurring in the patient. We can't necessarily fix the ribs with a quick fix. That's going to take some time, possibly even surgery. So the rib fracture is less of a concern than it is for the rib fracture causing another problem. A hemothorax is basically blood now causing the lung to deflate. That also needs to be rectified by a chest tube. And then, as I mentioned about air doing it, that's a pneumothorax. Tension pneumo is that basically that air building up or that pressure building up and causing deflation or pressure on the lungs that the lung cannot inflate and start shifting everything over to one side due to that amount of pressure. Okay. Pleural effusions are basically abnormal collections of fluid in the pleural space. They may or may not put a chest tube to drain that fluid. It is consistent with disease. And some of the causes are listed here. If you have increased pulmonary capillary pressure in the lungs, decreased oncotic pressure. So I think about the loss of albumin with poor protein amounts in the blood because that's helping keep fluid in the bloodstream. If we have low albumin levels, then that fluid can kind of escape and start third spacing, essentially going to different parts of the body out of the vascular area. Permeability of pleural membrane. So you'll find diseases that cause increased capillary permeability, and that causes fluid to leave the intravascular space and go into the interstitial space as well. Or the lymph system being obstructed. Empyemas, by definition, is purulent fluid. It's pus-like. It's developing in the pleural space. Typically, the causes are pneumonia, TB, or some type of other lung infection. So to treat, in addition to possibly a chest tube, they can administer antibiotics. They can do a video-assisted thoracentesis type of surgery, which is that VAT that's listed there. Or they can do an open window thoracostomy, which is also a surgical procedure as well. It gives basically an area for that fluid to escape and drain out from the lungs. So that leads us to chest tubes. So chest tubes come in various sizes. You see the smaller ones are referred to as pigtails, and then the larger ones are your actual chest tubes. So I don't think I've ever seen a 40 French chest tube. That to me sounds like a garden hose. Typically, you'll probably see something probably in the 16 French, maybe 20 French range for an adult. Physicians will put these in. It depends where in the intercostal spaces what they're trying to solve. So basically air rises, so chest tubes would get inserted at the higher levels, while fluid and blood come down to the bottom of the lungs with gravity. So if we're trying to get fluid or blood, then the chest tube will be inserted lower. Okay. All chest tube insertions require x-rays just to identify location. And of course, chest x-rays would help the physician know where to put or place the chest tube. You as a nurse, you might be assisting this process. Okay? So the physician will become sterile. You'll be the unsterile hand that if they need something, you'll go get it, pass it off to a sterile field. And then once the chest tube has been inserted, they're going to probably secure it with sutures to the chest. And they're also going to put an occlusive dressing, which may look like a clear petroleum type of Vaseline gauze dressing, or it may be something like Zeroform, which is a yellow Vaseline impregnated dressing. And that's going to create a seal around that chest tube so that air cannot escape. And so we wall off any chances of having a sucking chest wound. And so then your job as a nurse is to get an x-ray. And then, of course, the physician will identify if it's in the proper place. Hopefully no other pneumothoraces were created in the process. And then your job is now to monitor the dressing and also manage the drainage system, which is the chest tube container that we're going to look at next. There are a variety of systems. I guess this is all Pleurovac. So the two manufacturers are Atrium and Pleurovac. They do the same things. So you can learn one or the other. You can learn both. It doesn't matter. They each have what we call dry systems or wet systems. So the two on the left of your screen are your dry systems, and the two on the other side with the green oval circles are the wet systems. So you'll see that with dry systems, with the yellow circles, that gauge or that dial is what controls the amount of suction that you have, as long as it's connected to a wall suction. Okay? So let's say chest tube gets put in. More commonly, you're going to encounter the dry systems for both Atrium and Pleurovac. You get an order from the physician to maintain a negative 20 centimeters of water suction. Okay? So how do you accomplish that? You take the connector tubing, and all of you are familiar with the Yankar and the suction canister and the manometer that controls the suction. Okay. So it's similar. You still have the same container. Nothing's going to come out from the chest tube drainage system into that container, but you're likely using the same container because that's how you're going to get the suction, right? So you have the connector, clear connector tubing. That end attaches somewhere, and you'll see it. It's very identifiable onto the Pleurovac, and then the other end connects to the suction canister. You can turn up your manometer as high as you want because what controls the suction is the dial in the yellow circle. Okay, so you're going to put that dial where it says -20. Now it's at 20 centimeters of water, just as the physician is ordered. And a way that you can tell, if that dial is appropriate is, I'm going to get my pen here. Right here, where my line is coming off, there's a little window right there. When you have enough suction on the wall, you're going to see some kind of an orange plastic piece. It could be in the shape of a ball, it could be shape of a square, but it's going to rise into that window. And that's going to indicate whether you have enough wall suction. Okay? If you don't see that in that window, keep going up on the wall section until it appears. Okay? Now with the systems on the right, the wet systems, what creates the suction is how much do you fill up in this area right here. Okay, so you're going to use sterile water, you're going to pour it into that system, and if the physician wants -20, you're going to find the line that is equal to -20, and that's printed on the side of the container, and you're going to use sterile water and fill it up to that line. And then you're going to put it on wall suction. You do not have the same capability of knowing how much suction from the wall is sufficient. What you will end up seeing is some kind of bubbling in this chamber, but you will not get the rise like you did in the other system. You won't get something to rise in a window. Okay? So if you needed -10, that could be down here somewhere where you're using sterile water to fill it up to that level. That's kind of how these two differ, wet versus dry. It's up to the physician which one to use. And I can tell you the more oftentimes you're using the dry. Less frequent times you're using the wet, but sometimes after pulmonary surgeries where they've done wedge resections for, say, lung cancer, some of the pulmonary surgeons prefer the wet after certain types of pulmonary surgery. Okay.
I have a question. So my patient last weekend actually had a pneumothorax, had a chest tube put in the ER, and I came on, the next morning. He had a water seal, so I was expecting when you were talking about the wet systems to say they didn't need to be connected to suction because he was not. And I don't know if it's because he was 19 and they wanted him to still be able to move around. He had some other complications and actually ended up getting transferred for the VATS exploration surgery you were talking about. But I was, confused now when you just said the wet systems also get connected to wall suction.
Yes. So both can do suction, right? And the amount of negative pressure your surgeon or your physician wants will be dictated in an order. With the dry system, it's the dial. With the wet system, you're filling it up with fluid to whatever pressure they want, right?
Yeah.
Both can be put on water seal. What that means is that you're not connecting it to wall suction at all.
Got it. Okay.
So once you disconnect the dry system, once you disconnect the wet system, both are being put on water seal when you do that.
Got it. Okay, so I actually don't even know if it was a dry system or a wet system, but it was water sealed for the sustained suction.
Correct, yes. So
Okay.
both can do that.
Okay.
If you notice here, draw a line on the dry system here, this gets filled up by the clinician. So we're setting these systems up. They come with directions, but they're not usually too hard to follow. And there are attachments at the top here that aren't being shown in this picture that are adapters where we can fill these sections up with sterile water. Some might use normal saline, but sterile water is pretty common. So that gets filled up. This chamber here gets filled up as well because this is all connected down into here. And then the water line tends to be stopping right there. This section is your air leak chamber. That's where you're going to see, if somebody has an active pneumo that has a brand new chest tube, you're going to see bubbling in that window. As you see all of these lines, okay, some are shorter, some are longer. As you come over to the right side of this little window, they get shorter. So if the air bubble stops right at the first line, that's a small air leak. If those bubbles extend all the way to the left side of that window, that's a very large air leak. If somebody has a small pneumo that they've received a chest tube, they may have very little bubbling when that chest tube gets put in. And then as the pneumothorax resolves, the air leak will stop and you will no longer see it. And it's a sign that it's probably resolved. They'll do an x-ray to confirm. When somebody has a larger larger pneumothorax, you will get a larger air leak. But that should resolve over time as well as the pneumothorax resolves. And the air leak will become less and less as that resolves. Now let's say, because this is a responsibility of the nurse, let's say that you are coming onto shift, they already have this in place, you got report from the nurse prior to you that they had a small air leak. You go in to do your assessment, you don't see any bubbles. You're like, oh, it's resolved. Don't jump to that conclusion. Make sure that the wheel is not on the tubing, that the tubing hasn't been kinked, that the slide that occludes the tubing, and we're talking about this tubing right here that's connected to the patient, that something is not kinking to stop that air leak from showing up. If you've gone through all the troubleshooting for that, I see Lisa's hand behind her head. You have a kid behind you? No? So there's a hand coming up behind you, unless it's a ghost. Anyway, if something is occluding that chest tube, then you need to resolve that problem. Just don't jump to the conclusion that that air leak just all of a sudden stopped and therefore your pneumothorax is resolved. Right? Especially if it's drastic like that, because it's usually a gradual process. Now, if you've done all the troubleshooting and it is certainly resolved and you can't troubleshoot anymore and everything's patent, maybe it has resolved. But it will depend on the physician as to when they want to possibly put that onto water seal or even possibly remove the chest tube altogether. Okay, but for your documentation reasons. And you see on the right-hand side, you have the same air leak window as you do on the left. You see that all of the drainage compartments are the same, dry versus wet. That's where if you have any fluid coming out, say they have an empyema, pleural effusion, pneumothorax, that's where that's going to drain into. And you would continually keep, by marking on the side of these things, you would be continuing to tabulate in your output as to how much chest tube drainage has accumulated for your shift. This chamber, whether you're dealing with dry versus wet, will move with inspiration and exhalation, and that's called tidally. Okay, that's normal. And then as far as the wet system, the dry one doesn't make any noise when it's on suction. The wet one will. And oftentimes I've had patients ask if it's raining outside because they can hear that bubbling all the time on the wet system. Okay. Especially hooked up to suction, they typically will not hear it if it's a water seal. So if you have a patient that's on wall suction and you have to get them up to ambulate them, you don't want to clamp anything off. You still want to leave the system patent. All of these systems have hooks that can be hung on the pole, the IV pole that the patient can wheel around with them. But once you take them off wall suction, you are putting them on water seal to accomplish that activity. Okay. And that's fine until they get back to their room when they can go back on suction should the physician want them to be on suction. Now, there are videos on Canvas for the atrium, not for the pleurovac. But again, they're very much the same. This is the atrium. Wet system on the left, dry system on the right. So you see this dial here, and that's going to be kind of what you see on the pleurovac as well. Right now it's set to -20. This system has what we call like the bellows, which is like this accordion thing that once you reach suction, this will pop out and line up to this arrow. And that means you have adequate wall suction. This one's filled up, so you can see the water turns blue in these chambers, and that helps you identify the air leak in both of them. You see on the wet side, you see the water is pretty much up to the -20 line. But again, there's 15 right there, and there's 10 right there. So you can see, depending on what your physician orders, that's where you fill the water up to those. Any questions? Now, again, Atrium does a really good job. There's a PDF for the pleurovac that you can read as a resource on Canvas, and there's also videos for Atrium, which are very good about, shows you from pretty much setup to management for the Atrium on Canvas as well. Okay, so I think we pretty much talked about all of these things. When to clamp, rarely are you ever going to clamp a chest tube. The only time you really want to clamp is if you are troubleshooting whether or not you have a leak in the tubing. In other words, did the tubing become torn, or is there some kind of puncture in the tubing that's causing an air leak? So typically, if I have somebody that had a consistent small air leak or maybe no air leak at all, and then all of a sudden they have an increased air leak, or they have an air leak if they didn't have before, then I need to troubleshoot my system. Did the chest tube come out of the chest wall? That'd be the first thing I check. If the chest tube came out of the patient, I need to cover their wounds, right? Ideally use sterile gauze and gloves, but oftentimes that's not available, so you just want to use something clean to cover that wound up, because you don't want them to end up with a tension pneumo. And then someone needs to call the physician for you if you can't do it yourself to come and evaluate the patient. If the chest tube is still in the patient, then maybe something's wrong with my system. Did something get disconnected? Did the tubing that's connected to the chest tube, is there some kind of tear or opening in it that is causing the air leak to occur? And that's where you kind of clamp sections of it to see if the air leak stops or if it continues. And if, as you go down the tubing, the air leak all of a sudden stops, then you do have a leak in your tubing, and you can go and get just extra tubing to use to connect to the system and to the patient. You don't have to replace the whole system. Now, a couple of caveats is that these systems can hang on beds, but oftentimes our beds go very close to the floor. And so if they're hanging underneath the bed, they can get crunched as you lower the bed to the floor. So make sure it's not under the bed when you do that. And then sometimes they have legs too, that you can pull the legs out and set it on top of the floor, but then people kick it over, and then everything gets contaminated and you have to start fresh. So if I leave it on the floor, I usually add tape to the legs so that it's not so easy to knock over. Questions? Okay, so this is a good stopping point. Let's go ahead and take our next break, and we'll come back at 3.